Thank you to the Seattle Science Foundation again for the opportunity to speak. Tonight's topic is Scheuermann's kyphosis. And by way of outline, we'll touch upon the background regarding this interesting disorder, provide some definitions, classifications, dive a little bit deeper into the proposed etiologies, clinical presentation, also discuss the workup from a radiographic standpoint, and then also discuss the management, non-operative and operative considerations. And I think a big part of the discussion here will focus on complications and their prevention. This will then be followed by three very interesting case presentations, which will be presented by one of our fellows, Andrew Swires, moderated by Dr. Bervin, then followed by Dr. Aaron Clark, one of the neurosurgeons here, who I work with closely, and then followed by another fellow presentation, Richard Roberts, moderated by Lionel Metz. So I think it's always interesting to start with trivia of the eponym. So Scheuermann was a Danish surgeon who reported first in 1921 on this disorder. And really, up until this point, kyphosis in the young adult or young child was considered secondary to muscular spinal insufficiency. And he's the first that presented that it resembled Kyphosis disease and termed it Kyphosis dorsalis juvenilis. Since then, even though that was a proposed etiology, really the etiology of it is not known. It likely is multifactorial, and listed below are some of the proposed etiologies or contributors to the disorder: cartilage bone disorder, including osteonecrosis of vertebral apophyseal rings, juvenile osteoporosis, and disorders of the cartilaginous matrix. Mechanical factors have also been proposed as reasons for the development of it. Excessive axial spine loading commonly occurs in overweight individuals. Whether weightlifting has any influence on it, unclear. Reduction of the sternal size, a shortening of the ischiotibial musculature. There clearly is a genetic component to this, proposed to be autosomal dominant. Nearly 75% have some form of hereditary disposition. There's a high degree of penetrance and variable expressivity. Another Danish surgeon, Sorensen, provided us with some radiographic criteria that differentiated it from postural kyphosis. You can see the three criteria on the right: wedging greater than 5 degrees in 3 consecutive vertebrae or more, thoracic kyphosis of greater than 40 degrees, and then irregularities in the vertebral end plates, which is what Scheuermann originally had observed radiographically. Another little interesting tidbit of information is that to come up with these criteria, Sorensen evaluated wedging of over 4,665 vertebrae. So pretty painstaking work, but it's held a test of time. In terms of classifications, broadly, there are two types. Type 1, which is considered a typical Scheuermann's kyphosis, is shown on the left, is thoracic spine. This is 75 to 80% of cases. And then there's the atypical or type 2s, as you see on the right, which are focused in the thoracolumbar junction and the upper lumbar spine. Happens about 15-20%, 25% of the time. It can occur in the cervical spine and purely in the lumbar spine, but I think it's so infrequent, it's almost not worth a discussion. In terms of the clinical presentation, it is quite variable. There tends to be a male predominance. It does occur in teenagers, but as we'll go through in the several upcoming slides, that patients who are treated non-operatively ultimately can and will be seen in their adult years. And so it's important to understand what the presentation is, even in the adult situation. Commonly, it's pain over the area of maximal kyphosis. If that's the thoracic spine, with thoracolumbar junction, the type 2s tend to have worse pain scores. In order to maintain an upright sagittal alignment, an appropriate sagittal alignment, there is compensatory hyperlordosis of the cervical spine and the lumbar spine. So patients can present with neck pain and lumbar spine from that hyperlordosis. You can see on the right side, back prominence, anterior shoulder infolding can be cosmetic concerns that patients will discuss. And then patients may have difficulty lying down. I had one patient who couldn't put his head on the pillows and required 3 or 4 pillows to keep his head upright to prevent that hyper cervical lordosis causing neck pain. Neurologic impairments, many references will state that it's rare. However, this is a nice study from the WashU group in 2014 that found that there was a prevalence of nearly 10% abnormalities in neurologic findings. So I wouldn't consider that terribly rare. It does deserve closer inspection neurologically of these patients, and it's something that should not be overlooked. In terms of the workup, one first step is to assess the flexibility of the deformity. This can be done with standing X-rays, extension X-rays, but most commonly, and I think most importantly, the supine X-rays that are performed over a hyperextension bolster, as shown in the image here, with a lateral radiograph can be taken. Those can really differentiate between more flexible areas and more structural, rigid areas. And then MRI, this is a debatable area, but what's not debatable is if they have any neurologic symptoms, then they should get an MRI if they have neurologic symptoms. If they don't have any neural symptoms, that's where it's debatable. It assesses whether they have any asymptomatic disc herniations, stenosis, and syrinx. This is a nice study from Peter Newton and others who evaluated 86 patients with a mean preoperative kyphosis of 76 degrees, and they looked at MRI screening in patients who underwent surgery. They found that there were 17 spinal cord abnormalities, 2 low-lying conuses, 15 syrinxes with no associated Chiari malformations, and disc herniations were common, but 5 levels per patient. Interestingly, 1 to 2 levels caudad to the apex. In 5% of patients, the operative plan was changed secondary to findings in the MRI. And because of this, one of their conclusions was all patients should obtain MRIs preoperatively. Another one, this is a case report quite a while ago in 2001 by Clifford Tribus, presented on a 16-year-old boy with progressive Scheuermann's kyphosis, underwent a posterior instrumented fusion, and during the instrumentation, lost all signals to his legs. A wake-up test was performed that demonstrated no function. So at the time the surgery was aborted, and by the time the patient got to the operating room, to the recovery room, had recovery of his neural strength. But post-op CT myelogram demonstrated that there was severe stenosis from T10 to T8 at the apex of the deformity. And so again, they stated that the current author obtains a thoracic MRI before the surgical correction of any patient with Scheuermann's kyphosis. So in terms of treatment, once you assess the flexibility, get an overall magnitude of the kyphosis, determining what and how to proceed next is important. So patients who have a thoracic kyphosis less than 30 degrees, usually observation, pharmacologic management, physical therapy is the first line of treatment, especially in adolescents. For patients, especially children who have curves that are 60 to 75 degrees, hyperextension bracing can be used. It's best for patients with a kyphosis less than 65 degrees and who have pretty good correction in a brace. And then those who may warrant surgery off the bat are those with curves greater than 75 degrees. In the patients with smaller curves, surgery can ultimately be recommended if they have failure of non-operative treatments. They have intractable pain, unacceptable cosmesis, and deformity progression. Neurologic deficit, I think, would be a more strict indication for surgery. And then if a patient really has a severe deformity, cardiopulmonary distress, if they have cardiopulmonary distress, surgery also can be indicated. I think a lot of us are interested in knowing what the natural history of untreated Scheuermann's kyphosis is. This is a nice study from the Iowa group that looked at 67 patients, and they compared them to age sex max controls. Their average follow-up was 32 years. The follow-up was quite variable, 10 to 49 years. And they found that the patients in adulthood had more intense back pain, jobs that tended to have lower requirements for activity, less range of motion and strength of trunk extension, and definitely at different locations of pain relative to those without Scheuermann's. Interestingly, there was no differences between patients with Scheuermann's and those that didn't have Scheuermann's in adulthood in terms of number of days absent from work because of pain. Extension pain interfered with ADL, self-consciousness, self-esteem, social limitations, use of medication for back pain, and level of recreational activities. They found that patients who had kyphosis greater than 100 degrees with an apex on the thoracic spine did have restrictive lung disease as assessed on PFTs. So, see one of my patients 4 or 5 years ago comes to the clinic, 55 years old, clearly has Scheuermann's kyphosis that was treated non-operatively and as an adolescent, and has 85 degrees of residual kyphosis. And it really brings up the question is what to do. And if considering surgery, what are the options? So there are two options, anterior release followed by posterior versus posterior only. Anterior release is one that seems to be somewhat historic at this point, but I think it's important to understand what it is. Clearly an anterior operation that involves wide, complete radical discectomies, and then structural allograft can be placed, structural cages, at the time usually titanium mesh cages, but morselized allograft has been shown to have similar efficacy and outcomes and definitely decrease costs. So morselized allograft placed in the disc space achieves good union. This can be done through an open operation or thoracoscopically with relatively good results. And earlier studies, you can see these date back quite a while. The 1980s showed that there were relatively good outcomes of this. Now, the arguments against an anterior approach, there are several: approach-related morbidity, pain, pulmonary function, appearance of having an additional scar, especially as an open thoracotomy incision, increased operative times, 2 stages, and increased EBL. But it really brings up the question is, does it provide better correction? And can the same be achieved with a posterior-only operation? This is a prior study that said relatively good results, but if you look at it over time, patients had a commonly significant loss of correction through the operative levels. And it brings us to what are the posterior-only strategies that can be used to address these deformities, and really having the advent of posterior column osteotomies and wider release to release the spine has been instrumental in providing better correction of these deformities from a posterior-only approach. The Ponte osteotomy, the original article as shown here, was originally described for Scheuermann's kyphosis. And in addition to posterior column osteotomies, I think 3-column fixation with pedicle screws compared to just fixation of the posterior column with hooks has been also very, very key in achieving similar corrections. One of the big questions does arise: do discs open anteriorly from a posterior-only approach in Scheuermann's? This is a nice study from Peter Newton and his group that demonstrated that there were the same changes in intradiscal angulation with posterior-only surgery and those that involved an anterior release. So I think the field in general has gone away from the anterior release for a lot of these and is focused primarily on the posterior strategies. This is a nice study in 2006 from the WashU group that found that posterior-only approach had decreased operative time, decreased blood loss compared to those that had anterior and posterior operations. This is a recent, relatively recent systematic review and meta-analysis looking at the same posterior-only versus circumferential fusion for Scheuermann's disease. They found that posterior-only surgery using posterior osteotomies can achieve correction of Scheuermann's kyphosis as successfully as anterior-posterior surgery does. If you dive into their data, you can see here that when posterior osteotomies are not used, it actually favors an anterior posterior approach, as you see on that upper row. But when you involve the Ponti posterior column osteotomies, really there's no difference in correction. Now, they also looked at screw only, so pedicle screw only constructs versus hybrid, but they did not involve hook constructs only, and they found that it was a wash, that again, similar correction depending, irrespective of the type of instrumentation. So we talked about the types of surgeries. I think it's also important to touch upon the utility of surgery. If you look at these nice studies, these are focused on adolescents. This is not in the adult, but several studies have corroborated these findings, and surgery improves, irrespective of approach, health-related quality of life scores with the greatest improvements in pain and self-image domains, as well as the mental health on the SRS 22 scoring system. This prospective comparison of patients who were treated operatively versus non-operatively also demonstrated that surgically treated patients at 2 years have better improved SRS 22 parameters, less pain, greater satisfaction with appearance, and greater satisfaction with overall outcomes. So for this patient, the adult, we decided to do a posterior only operation from T2 down to L3. And you can see here a nice restoration of his sagittal alignment. If you focus closely on the lateral post-op image, you can see that those disc spaces really do open anteriorly compared to the preoperative, where they're nearly kissing at the ALL anteriorly. While these can produce significant improvement in function, cosmesis, and pain, I think it's important that we don't overlook the relatively high complications with these surgeries. This is a study from the SRS M&M committee database many years ago, looking at both adults and children with Scheuermann's. You can see here that overall they had a 15% complication risk rate. There's quite a smattering of complications that were reported. You can see here wound infections, nearly 4%, a little bit higher, and the patients that are older, greater than 10%, nearly 10%, and those that are aged greater than 50. And then implant-related complications, I think, are also what I'd like to talk about next, because that's definitely gotten a lot of press. And those implant failures or alignment-based failures we should talk about are PJK and DJK, so proximal junctional kyphosis on the left and DJK, distal junctional kyphosis, in the middle. You can see the rates there approaching 40% for PJK, which is quite staggering, and then nearly 20% for DJK. The causes can be numerous: vertebral body fractures, posterior ligamentous complex disruption, progressive distal disc degeneration, as well as non-union. The risk factors, the mechanisms for it are multifactorial, and it's not one or the other. It's by a combination of all these things: appropriate selection of levels, which we'll touch upon shortly, failure to restore sagittal alignment specific to the patient, variability of pelvic incidence, implant rigidity at the junctions, trajectory of screws, especially the LIV screws, anatomic for straightforward, and then the question of TP hooks versus pedicle screws at the cranial junction, the amount of correction, patient's body habitus. Many of these patients are quite overweight and obese, and taking that into consideration, I think, is important. And there probably are some neuromuscular factors that play into this. PJK prevention. There are many studies that have looked at this. These are two nice ones that really demonstrate that the selection of the proximal UIV is key. T1 and T2, I think, are a better place to stop. And then getting at the sagittal realignment and restoring a patient's shape per Rousseli, I think, is also paramount to this. Avoiding a kyphosis pelvic incidence mismatch, aiming to correct kyphosis close to the patient's pelvic incidence is what one study recommended. In terms of DJK and its prevention, the major focus here is around the LIV selection. There are two proposed LIV stop areas. One is the stable sagittal vertebra, as shown on the left, And then the second on the right is a first lordotic disc. The first lordotic disc was one that was recommended more traditionally, and then the stable sagittal vertebra is something that's quote unquote newer. I wouldn't say it's new, but it's relatively newer. And it has been demonstrated that stopping at the sagittal stable vertebra decreases one's risk of DJK significantly. This is a nice study from in the Global Spine Journal in 2017 that found that those patients that stopped at the sagittal stable vertebra, group A, in the middle column there, had a 5% risk of DJK. And then those that did not stop at the sagittal stable vertebra cranial to it had more than 36% rate of DJK. This is confirmed in this study in 2009 that the distal end of a fusion for thoracic hyperkyphosis should include the sagittal stable vertebra. And interesting, levels that include the first lordotic vertebra but not the sagittal stable vertebra are not always appropriate to prevent postoperative distal junctional kyphosis, was their conclusion. This is a figure from that study that showed that the patient with Scheuermann's, the first lordotic disc was L2-3, the LIV was L3. Patient ended up developing a distal junctional failure. You can see their non-union screw breakage, and it ultimately required extension to L4, which was the stable sagittal vertebra, which may have been a better option to start with. This is another example of patient who had a first lordotic disc at L1, L2, and was stopped at L2, developed distal junctional failure and kyphosis at L2-3, and this patient's stable sagittal vertebra was L3, which probably would have been the better point to stop selection and may have decreased the risk of this distal junctional failure. I think also, in addition to the level, the LIV level, other things to consider, especially in the adult population that's obese, has osteoporosis, are other prophylactic instrumentation strategies, cement augmentation of the LIV, including an interbody fusion between the LIV plus 1 and LIV, and possibly including sublaminar banding or hooks versus wiring at the LIV. My technique is to do a direct lateral approach. It prevents disrupting the posterior column in terms of fusion bed at the LIV plus 1, as well as cement augmenting. You can see this 23-year-old, very obese gentleman, BMI 38, with Scheuermann's kyphosis, thoracolumbar, had a lot of pain, cosmetic disorder, cosmetic issues. We did a T2 to L3 with this preventative strategy, including an interbody from a direct lateral approach, as well as cement augmentation of the last screw. And overall, his posture, he said he grew, is a lot happier. His mom noticed that as well, and has been junction failure free for the last 2 years or so. So in conclusion, Scheuermann's kyphosis is a disease of the adolescents, but can cause persistent cosmetic problems and pain in adults requiring intervention. Surgery provides significant improvements in health-related quality of life scores, pain, cosmesis, and mental health. However, it does have a relatively high complication rate, including PJK and DJK, and it's very important to understand the preventative strategies as well as choosing appropriate levels for surgery to minimize the chance of these occurring. So thank you. We'll now move on to our interesting cases, but I'm happy to take any questions about this.
Alekos, thank you. That was a great 100-year summary of the disease. So why don't we go on to the cases?
Okay, great. Well, I'd like to introduce our first speaker, Andrew Sawires. He is coming from us from Lenox Hill, New York, and we're very happy to have him on our team. He's going to present a relatively historic case of Scheuermann's kyphosis, and the moderator will be Dr. Bervin. Andrew, I'll roll through the slides and feel free to go through them.
Thank you, Theologis. Just to begin, my name is Andrew. It's very nice to meet you all. Thank you all for having me. Dr. Bervin actually had to run to the OR just about 20 minutes ago for an emergency case, just as a heads up for everyone. So we'll be missing our moderator for this case. But to start, this is a historic case that was done by Dr. Bervin, and it really goes through the series of how in the past we used to combine anterior posterior techniques, as Dr. Theologis spoke about, and really more recently with the advent of newer posterior fixation and pedicle screws, we've transitioned more to posterior only technique. So this is a 17-year-old gentleman with a rigid deformity with about a 92-degree curve with the apex at T8, as we can see here on the lateral imaging. Next slide. And this is these are intraoperative images showing the endoscopic technique, moving the lung pleura out of the way. Next slide. And exposing really the vertebral anatomy. Here we can see using a peanut to really sweep the vessels and provide a safe exposure to the disc, which was taken out in the next slide using a discectomy technique in next two slides to really achieve the anterior release and allow for that posterior correction to augment it, given the old screw instrumentation and screw systems not being as robust as they are today. So if you move on to the next slide, here we can see the intraoperative placeholders placed for the lumbar instrumentation, and you can see with the anterior release, we got quite a nice correction from about 92 degrees, about 40 degrees of correction from when I measured it on my own computer. And then if we move on to the next slide, we can see there adding the lumbar screws L1, the lower instrumentation T11, 12, and L1, and then using hooks above up to T2, we're able to really reduce that or achieve the correction from 98 degrees preoperatively to 48 degrees postoperatively. And next slide, we can see them side by side. Really, what a nice correction we obtained. And I believe the next slide shows the clinical images showing the small portal sites for the endoscopic thoracoscopic anterior release, and we can see the midline incision as well. And then the next case goes on to highlight a more recent technique using posterior only instrumentation. Here we see a patient with a flexible deformity, so they have an 85-degree thoracic kyphosis, again centered around T8 to 9, and using an extension bolster, we can see that we are able to achieve 50 degrees pre-op of correction. So in this case, we actually went in and we used only a posterior incision, and we did multiple Ponti osteotomies and really achieved a good correction from 85 degrees to about 43 degrees using posterior only instrumentation from T2 to L1. Sorry, from T2 to L2. And I think we also have a clinical image here showing, sorry, it's missing from this PowerPoint, but the clinical image shows that the patient's able to stand up straighter. Really, the hump and the rigid hump that they had from their back is pretty much gone, and both the patient and their parents were very happy with the correction achieved. So it's really with the advent of these new pedicle screw systems and good fixation all the way up, to the upper thoracic spine, and using multiple osteotomies throughout the thoracic spines, that we're able to achieve this correction as opposed to in the past.
Well, Andrew, thanks for presenting that. If SIG's away, I'm happy to moderate it. Very, very nice examples of how the surgical strategies have adopted over time, and you can achieve a similar amount of correction with the posterior only approach relative to the anterior release plus the posterior. You can see here that the major improvement in this ability has been through the use of pedicle screws. That original case that you showed was of hooks, and while you can have, through cantilever maneuvers, the fixation is not as robust, and over time can lose fixation if it's posterior only. The circumferential fusion is key to those to ensure that they don't lose fixation over time.
You know what year the first case was? Did it need the use of thoracic pedicle screws? Well, might have, I would think. You know how long ago that first case was from?
Good question. Andrew, do you know? I don't know.
That I don't know, unfortunately, but I believe it was around 2006 or maybe a little bit before.
Team, just to make a comment on this, I don't think we should be discrediting the anterior release so much at this point in time. Yes, it is a difficult, and yes, we're doing a lot less of it, but there are still some rigid Scheuermanns that you can crank as much as you want with pedicle screws from behind and do as much as you want with the facetectomies. But that ALL is so tight, and there may even be some levels that are actually ossified or fused, that you may still need an anterior release. So let's not discredit it. Evaluate the patients properly ahead of time. As Alexis mentioned, do the hyperextension x-rays, see what kind of mobility you can predict to get out of those disc spaces, and then commit to your surgical procedure. Don't just automatically jump one way or another.
I'm very happy you brought that up, Izzy. I totally agree with you. And the preoperative planning is instrumental. There definitely is a role for anterior release for rigid deformities. What are your thoughts? And this gets into nuances of each deformity, and I think the surgical strategies will differ based on the apex of the deformity. But do you think that there's any role, or do you think that pedicle subtraction osteotomy in those more rigid case would be a good alternative?
So again, it all depends on the level and how you're trying to achieve a harmonious balance or a harmonious alignment through the spine. I do very little pedicle subtraction osteotomies now. I rely quite heavily on good facetectomies, Smith-Peterson or Ponti type osteotomies, and potentially some kind of anterior release. And I'll do that 9 times out of 10 before I'll recommend a pedicle subtraction osteotomy, especially in the thoracic spine. And maybe it's just because my coronaries can't handle the anxiety related to the spine shearing on you when you're doing that PSO in the thoracic spine.
I agree. Thoracic-based PSOs don't tend to have as much angular correction as in the lumbar spine. They tend to just shorten and somewhat symmetrically. So I agree with you. We shouldn't poo-poo the anterior release too much, because there definitely is a role for it, not only in the thoracic spine, but also in the lumbar spine. Well, let's move on, if everyone's okay, to the second case. And I'd like to present a very close friend of mine, Aaron Clark. He's an associate professor here at UCSF. We do all of our complex cases together, and he's going to show a really nice one of a patient who he took care of over several years. So Aaron, take it away.
Yeah, thank you very much, Alekos. I think in contrast to the previous cases, we'll touch on some of the challenges of taking care of a patient with Scheuermann's kyphosis as an adult. When I first evaluated this patient in clinic, she was 52 years old. Similar to the classic presentation, she had very severe and debilitating mechanical mid-back pain. It was worse with activities and improved with laying down. She did not have radiculopathy or myelopathy symptoms, and had actually had a very interesting past surgical history, not done by me, but she had, as you'll see, a multi-level kyphoplasty done in the community. And when her pain persisted and worsened, she had a spinal cord stimulator placed. Furthermore, she'd had multiple rounds of physical therapy, aquatherapy, injections, and on my physical exam, she was neurologically intact. Next slide. Starting with the scoliosis x-rays, you can see she has a little bit of scoliosis, but you can see better on the laterals that she's had really multiple levels of kyphoplasty done with cement augmentation of the levels through the apex of her deformity. Her thoracic kyphosis was 72 degrees, so kind of right on the edge there, and did have a hyperlordosis through the lumbar spine of 90 degrees. Her pelvic incidence was 70, but globally relatively well balanced. This was her CT scan, which is all that I could have obtained when I first saw her, but she did have the spinal cord stimulator removed because it wasn't functioning well or wasn't helping with her symptoms. And that allowed me to get the MRI scan that was discussed in Alekos' presentation. And you can see that she does not have any lumbar stenosis or thoracic stenosis. She does not have any spinal cord compression. Next slide. And ultimately, I devised a surgical plan of doing a posterior instrumented fusion from T3 to L2. I have found that when treating these patients, not only does navigation help because oftentimes the pedicles can be very small, but also the navigated drill guide helps me drill into that cement and be able to get good fixation in those regions. We did Smith-Peterson osteotomies as discussed from T7 to T10. And at T3, I did attempt some PJK prevention techniques, including transverse process hooks and ligamentoplasty from T2 to T4. And these are her preoperative films compared to postoperative films. And I believe the next ones, the next images show the angular measurements here, where preoperatively, again, she had 72 degrees of thoracic kyphosis and ultimately was corrected to 49 degrees and remained globally well balanced, although did have a bit of loss of lumbar lordosis. But overall, I was fairly happy with this. But you'll see follow up on the next slide, which was she felt in the short term had improved mid back pain. She was happy with her posture and noted some gradually increasing low back pain that I was following at the time. Next slide. But 2 years later, she did develop new right greater than left leg pain, which prompted me to obtain a new MRI and showed development of lateral recess stenosis at L4-5. Initially, I tried to treat this conservatively with injections and physical therapy, ultimately went on to surgery. And you'll see in the next slide, I just did a simple, minimally invasive right-sided L4-5 laminopharaminotomy, and then looked to the contralateral side and did a bilateral decompression through an 18-millimeter tube, which did help with her leg pain. But over time, in the next slide, you'll see she did develop continuing to increase low back pain. She also had some pain in the bilateral SI joint areas. And ultimately, I did a full evaluation of this, including CT scans and X-rays. And what you'll see here is that she developed DJK with significant lucencies around the bottom screws, and she was slowly starting to decompensate in the sagittal plane. So ultimately, we decided to extend her to the pelvis and do an L5-S1 ALIF, revise the L2 screw, again, extended the fusion to the pelvis and used bilateral S2AI screws that have a hollow core and so allow for some SI joint fusion as well. This is her ultimate construct, and then comparing sagittally preoperative to postoperative. And at this point, she's doing well.
Excellent, Aaron. The gift that keeps on giving. And
True. And I'd love to hear from panelists or other guests here. Would people have considered going to the pelvis in a patient of this age up front, or perhaps slightly less correction or different lower instrumented vertebra?
I think I may have missed it, but why did she have the original vertebral augmentations? What was the indication for that?
It was thoracic kyphosis and in mid back pain. It happened before I came to see her, but that's what I could glean from my history in clinic.
Because that's just a travesty.
I had never seen. I'll be honest. I had never seen this before.
Yeah, that's just a travesty. That's just someone not understanding the spine pathology that they're faced with. I would not have gone, to answer your question, I would not have gone to the pelvis right off the bat. I would have more than likely done something very similar to what you did there to correct the alignment as best you can and get her balanced. Has she been on any kind of osteoporosis treatment? Because looking at some of those images, I'd be concerned with that, and probably would have made sure that she had at least some kind of bone osteoporosis treatment as well with all of this.
Yes, I think that's a fantastic point. As you can imagine, she had great fixation through the areas of cement, but at the other areas not as much. And she was treated preoperatively with Forteo.
Good, yeah.
I concur with Isidore. I do have to say that this was bound to fail. This is a abuse of kypho/vertebroplasty. And you can actually see how these discs literally desiccated after this 5 or 6 level, whatever, so 7 level kyphoplasty. I was going to go into the psychology of these Scheuermann patients and go back to Alekos maybe, but then also Aaron and Isidore. There's a clear overlap of significant depression with these patients. And my question is, how much do you focus on kind of getting them optimized psychologically versus just saying, look, this is because of your bad back that you're so depressed? Because again, for me, this is a big struggle as I see these patients. And I'm right now having a patient with a BMI of 48. He has no myelopathy. He has an 85-degree curve, and he's flipping depressed. And it's just like, he just wants me to, quote, fix it. And I'm highly reluctant to enter that without a quid pro quo on the patient's part. So depression and Scheuermann's, that overlap that's cursed these patients since their 16, 17-year age group.
I think it's a great point, Dr. Chapman. I do try my best to get patients connected with pain psychology. I think all of us as spine surgeons deal with the workforce challenges within the pain psychology field and getting our patients in a timely fashion. And so in the absence of that, I think a lot of it has to do with reasonable goal setting from an operation with the patient right from upfront, what can be fixed and what likely is going to persist.
Yeah, I agree. There's definitely a high incidence of concomitant depression, and I don't think it's all chalked up just for deformity. So preoperative optimization through pain psychology or looping them in with a psychiatrist is key. Whether they buy into it or not is on their own accord. But if it's an elective operation, you do your best to optimize them beforehand. You know, in the pediatric world, at least some of those studies did demonstrate improvements in the mental health domain of the SRS-22, whether that's that improvement secondary to improvements in self-image or the pain itself. I think it's hard to tease out. There's probably a component of it, but I do think there's probably some independent psychiatric component to this that, depending on severity, definitely needs to be addressed preoperatively as best it can be. The one thing I wanted to also touch upon here, Aaron, is it brings up a good point of the LIV. A couple factors in the LIV. One is looking at preoperatively, the L2 area where you stopped. definitely seemed potentially reasonable at the time. L3 may have been a quote unquote safer bet. 2020 hindsight, especially in an older patient population, osteoporotic, and she's quite obese. The second thing is the screw trajectories. Looking at those, they look more anatomic. And so there's a lot of cantilever forces that those screws see. And if they're aimed distally to start with, they tend to have, I think, an increased risk of screw pullout or windshield wiping. Aiming them more cranially and trying to engage that cranial end plate of the LIV may, I don't know if it's true or not, may decrease the incidence of that. And then doing a cement augmentation down the level below also could be of use, and getting an inner body at L1-2. T-lift is an option. Lateral approach, I think, is a little bit more dicey around the thoracolumbar junction. But that area definitely is a high-risk zone, and getting union across that area is particularly challenging because you have to preserve that spinous process distally, which may compromise your ability to bone graft across that or get posterior lateral fusion too, especially if it's T12L1 area.
You totally agree. I think some of those techniques are certainly things that I routinely do now, particularly with cement augmentation, in more usage of lateral interbody fusion at the distal level. I think I wasn't doing as much at the early stages when I first treated her, but definitely something I'd consider at this point. Nice.
All right, guys. Well, I think we'll go on to the third case. This is presented by Richard Roberts, one of our current fellows. He stems from Michigan, and he's going to present a very interesting case by Lionel Metz, who's one of my colleagues, who treats a spectrum of spinal disorders. He's one of our pediatric specialists. So he has really unique insight into the adolescent Scheuermann's, plus how it extends into the adult side. This is an adult patient, but I look forward to the presentation and your thoughts.
Good evening. Thank you for having us. I'm honored to be here. This is a 66-year-old gentleman presented to our clinic with back pain. Predominantly states that the back pain is in his mid and low back, rates it as a 10 out of 10, states that it extensively limits his activity, whether that's sleeping, his activities of daily living, or working. He states that this pain is worse when the pressure is applied over what he calls the hump in his back. Tramadol seems to help with the pain a little bit, but physical therapy, activity modifications, and all non-operative measures have been exhausted. Gentleman denies any numbness or tingling in the arms or legs and does not have any weakness in his upper or lower extremities. Past medical history is significant for hypertension. He was a mechanic, but he had to retire early due to the pain, and he does smoke marijuana daily for pain relief. So this is his clinical picture. You can appreciate his deformity. Bilateral lower extremities are intact for sensation, normal strength, normal reflexes, no difficulty with tandem gait and negative Romberg. So these are the preoperative radiographs. We measured his deformity to be 87 degrees. There is a minimal dextroconvex curve of the upper thoracic spine around T5 and a levoconvex curve centered about T11. Preoperative MRI of the cervical, thoracic, and lumbar spine show that there's no central canal stenosis, no neuroforaminal stenosis, or any cord compression throughout his deformity. So our surgical plan was a posterior spinal fusion from T2 to L3 with osteotomies from T3 to L2. And you can see postoperative compared to his preoperative films. And we have some measurements there regarding his kyphotic deformity that we corrected from 87 degrees down to 47 degrees. Lumbar lordosis changed a little down to 47 degrees postoperatively, but intraoperatively, and while he was in the hospital, we were happy with our correction. Then about post-op day 25, the patient presented to our clinic with acute back pain after a series of a couple events that occurred after he was discharged from rehab. States that he has some low back pain after bending forward to feed his dog, and pain at the base of his neck after going over a large bump in the road and a transport van. States that the pain is worse with sitting up and lying down flat on his back, rates it as a 10 out of 10. Incision was intact, no drainage was noted. Sensory and motor exam was normal. But on imaging, we can appreciate the proximal and distal junctional failures here. So our plan was a two-stage procedure. We plan to do a lumbar interbody fusion at L2-3 via direct lateral approach. And second stage would be a revision of the posterior fusion up to C5. We plan to revise and augment the L2 and L3 screws and do osteotomies up to C7 and then at L2 and L3. You can see that postoperative imaging here. Through that, the final correction of his kyphosis was 41 degrees from 87, which we were happy with. You can appreciate the inner body at L2-3 and see that our construct went up to C5. So his most recent follow-up clinic visit was 12 weeks from his index surgery and 6 weeks from his revision surgery. At that time, he had been discharged home from his rehab facility. He was happy with his appearance. He had some improvement in pain, but we're still working on that currently. Sensory and motor exam was normal, incision was healing. We were happy with our outcome of our revision surgery.
Thanks, Richard, for presenting it. Lionel, do you want to comment on it?
Yeah, this is older adult Scheuermann's patients, so certainly more rigid than our typical teenage or young adult patient, but did not require any anterior work to get segmental correction. This was all just done with type 2 osteotomies. Originally, when I had counseled the patient in the office, I had discussed a fusion up into the lower cervical spine, but we sort of came to a shared decision to not instrument the neck. And probably in retrospect, I think the proximal failure was predictable. When you look back at his MRI, you can actually see that although the measurement that we quoted was from, I think, T4 to T12 of 84 degrees, he was actually still kyphotic. Probably that top left shows it the best. You can see the upper thoracic spine. The kyphosis continues all the way up probably to T1 or so. And so stopping below a kyphotic level and achieving that much correction is probably fairly predictable that that T1 would get pulled off of T2, which was his mechanism of failure. Then distally, I've sort of learned this lesson several times, unfortunately, with these adult patients with these floating fusions that don't go down to the pelvis, is there's a ton of strain on that lowest instrumented vertebra. Those screws, no matter how rigid they feel going in, you put that fixation juxtaposed to a long lever arm and a disc that's not as stiff as a pediatric disc. So even if the disc doesn't have advanced degeneration, see on MRI, and in this case, it would be the 2-3 disc that we're talking about, there's still a high strain environment on those L3 screws because that disc is an adult disc. It's not going to resist those flexion forces. So I agree with you, Alekos. My standard now is to do a lateral interbody fusion at the LIV, particularly if it's above an L3 LIV. 2-3 is a great level, or 3-4 is a great level for a lateral, very kind of straightforward. I don't like doing it before the major operation, so usually I'll stage it, a week or two later. And that was actually the long-term plan for this gentleman, but time sort of slipped away and he actually came back with a failure before we got a chance to augment that disc level. But I agree. I think the most important mitigation factors for distal junctional kyphosis are an interbody at the lowest disc, right above the LIV, cement augmentation of at least the lowest screws. I think we cement augmented L2 and L3 in this case. And then proximally, I think it's sort of up for debate, but there are probably some cases where we do need to go up into the cervical spine in that primary setting. And if I saw this gentleman's twin brother tomorrow, I'd probably, settle on a C6 or C5 UIV.
Hey, Lionel, this is Jens. It's a great case, and thanks for being so open about discussing something that affects all of us. And I totally concur with the bottom end needing a cage. Any thoughts on distal banding? Any thoughts on offloading screws by using same level upgoing sublaminar hooks? Anything along those lines outside of the usual LIV or LIV -1 cementing?
Yeah, no, I think it's a great point. So the failure mechanism typically is going to be a fracture through the pedicle, and kind of that windshield wiping effect of those screws as those screws get pulled up by the rest of the construct. You see this kind of change of alignment to that anatomic position. So in this case, there's actually, I believe there was a bit of a pedicle fracture as well. But I think one teaching point is you don't always have to extend patients down. If you can, if you can get to it early enough, get good fixation, you don't need to necessarily extend them down. I think banding or wiring or placing a hook under the lamina is a good way to sort of keep that pedicle together. So the pars, the lamina, and the spinous process are distal to that, where that fracture, or distal to those screws. So you can offload, or you can prevent that pedicle fracture by augmenting at one of those structures. I guess the trade-off is you're disrupting some of that soft tissue attachment to the spinous process of L3 or whatever the LIV is. But I agree. I think that may have been another way to mitigate what happened here.
Hey, can I just kick in? This is the typical degenerative guy versus deformity guy argument. But you had a 66-year-old retired guy with some back pain who had no neurologic, who's got a wide open spinal canal everywhere going. And you put a lot of hardware in, did a lot of surgery, and you bought him potentials for more problems than he had coming in. So, it kind of falls in there. You certainly made his x-rays look a lot better, and structurally and radiographically and geometrically, I can't argue with it, but it's, is this the right guy to do this kind of surgery with this kind of potential revision rate?
Yeah, no, I think this
Sorry.
No, I think you bring up probably the most important point of the night is that surgical indication for any, deformity, but particularly adult deformity is paramount. You take every patient walking around with this x-ray and do this to them, you're going to have at least half those patients that hate you afterwards. So you have to figure out which of these patients with this x-ray are miserable because of the pathology. And this guy, we followed for over a year and put him through, trials and tribulations of non-operative treatment. And he proved that he was kind of that miserable patient that could benefit.